So today we are going to learn about artificial respiration. This is something we usually do when a patient or a person is not able to breathe by himself. If someone has momentarily or temporarily lost his breathing capacity due to any reason, due to any trauma, some person may be drowning, or there might be electrocution, means someone has got an electric shock, or severe trauma. Many things can cause this condition that the person is not able to breathe. So in that condition, if we are present at the scene, like at the scene of the wherever this happened, like some person is drowning, that person was being rescued, and you are present at that position, at that spot. So these things you can do to the patient to probably save the life of the patient. So what is artificial respiration? It is an emergency life-saving procedure. Again, I am told you this. This is breathing induced by some manipulative technique when natural respiration has ceased or is faltering. Means when the person is unable to take natural respiration, which you normally do, or he is completely unable to take, or there is decreased respiration. In that case, we aid the patient with artificial respiration so that he can be able to breathe, and we can the patient can safely reach to hospital till further help arrives. Till that we can save the patient. And when the lungs stop functioning or sudden stoppage of breathing. So there is one indication of artificial respiration. That is, the patient is not breathing, no respiration, but heart continues to beat. But the heart rate is there, but the patient is not able to breathe. If heart rate is not there, we have to do CPR. So that is a different issue. So today we are discussing only about the respiration part, not about the cardiac part. So what are the conditions when this thing can occur, when sudden stoppage of breathing can occur? The person, suddenly he is not able to breathe anymore. These are drowning. So suppose someone has drowned. He has engulfed a lot of amount of water, and water is also gone inside his lungs. So in that case, that person is unable to breathe. So that is one case. One is electrocution, means someone has got heavy voltage of electric shock. That might be a case. Then anesthetic accident, like someone has been given anesthesia. So that is an hospital thing. Or sometimes like someone has taken any drug or anesthetic type of agent, so due to which the person is not able to breathe. That might be another cause. Then carbon monoxide poisoning. When there is a poisoning, like someone has gone into a fire, so there are different kind of harmful gases there. So exposure to those gases may also cause this cessation or stoppage of breathing. So that is the case. An accident. I told you already that in accidents, if some person has got severe kind of trauma, so there might be shutdown of the respiratory centers in the brain. So in that case, that person may not be able to breathe by himself. Then strangulation. If someone was being strangulated, or he tried strangulation by himself, or someone else strangulated him, or due to any reason, or hanging, in those cases also, the person will be momentarily unable to breathe. Then in poliomyelitis, do you know about poliomyelitis? So poliomyelitis is a condition. It is caused due to a virus in which the person will have respiratory paralysis. There will be respiratory paralysis of the muscles. So in that case, the person will not be able to breathe. And in myasthenia gravis. So these are the conditions in which this thing can occur. Certain stoppage of respiration or certain stoppage of breathing can occur. So before giving artificial respiration or artificial breathing, there are some steps, some things we have to make sure. So what are those things? These are those precautionary measures. These are their tight clothes should be loosened. The patient, if he is wearing tight clothes, their clothes should be removed or they should be loosened. Patient should be kept warm. If there is frothing means if some saliva or like bubbles, or sometimes you know not frothing, what frothing means, there's salivation or secretion is coming out from the nose and the mouth. So these things have to be cleared. Otherwise, even if you are giving artificial respiration, that air will not go to the lungs. So these things have to be cleared first. Then denture is removed. Denture means when someone is having artificial tooth, because someone might have dentures, they might not be having some tooth in the upper jaw, in the lower jaw. So that might be having some dentures. So if you are giving respiration with allowing the dentures might go into his stomach or into his lungs or anywhere. That might cause even more injury. So that denture has to be removed carefully. Then patient is taken to fresh atmosphere. So suppose one person is drowning, or suppose one person has been electrocuted, or he is in a accident case, or like in the spot of accident or spot of whatever has happened to the patient. So we cannot keep him there, na. So suppose someone is drowning, we cannot keep him in the water and start respiration. We have to bring him to a safe place. Similarly, if someone is getting electrocuted, we cannot go and touch him and start breathing as artificial respiration. In that case also, we have to bring the patient to a safe place, and then we will start the respiration. So these are the precautionary measures we have to take before starting the respiration, artificial respiration. So there are two types of artificial respiration. One is manual, that as a person you can do, even if there is no such equipment present with you, you can do this manual artificial respiration. And another is mechanical. In that we need specific type of instruments for the patient. So today we are mainly going to learn about manual only. Like if we are present at the scene, what we can do to save the life of the patient. So mechanical is actually in hospital. So in today's class, we will be learning that we will be resuscitating the patient up to our level best. We will try to keep the patient alive till the help arrives, and we will call for ambulance or help. Then whenever the patient is taken to the hospital, rest will be taken care of there. So today we will be learning about the manual method only. So in manual method, what are the methods? One is Schafer's method. So this method is done in the prone position. A prone position, anyone can tell me prone position, what is prone position, what is supine position? Prone means the patient will be lying towards the floor. His face will be towards the floor. And supine means the patient's face will be facing upwards. So that is called supine. So Schafer's method is done in prone position. Then there is Holger-Nielsen method. Then there is Sylvester's method. And one is mouth-to-mouth respiration. There are mechanical methods called negative pressure breathing, that is drinker's method, positive pressure breathing, tank respirator. But we will not go into those details today. Firstly, what is Schafer's method? So in this method, the patient will be in prone position. The patient will not be in supine position. Ideally, we will do this method if the person has drowned, if this is a drowning case. So in drowning case, what happens? I have told you that in drowning case, the patient will engulf a lot of water, and some of the water will go into his lungs. That will cause difficulty in his respiration, because already there is water inside his lungs. So his lungs cannot perform at its optimum capacity. So the person will either have difficulty in breathing, or he will completely stop taking respiration. So in this case, how can we help? So in Schafer's method, what we will do? The doctor will kneel near the patient's waist and put his palm on the patient's loin. Loin, what do you mean by loin? Which side? There are many sides, na? Posterior end of the waist. Yeah, it is actually between the 12th rib and the hip. The place which is between the 12th rib and the hip, this part is called the loin. So in this case, what we will do? We will make the patient we will take the patient's arms and make them do like this. The patient will be lying down in this position, and the doctor will bend to one side. We will keep our knees there. You are seeing that, na? The doctor will bend his knees and sit like this, and our arms will be straight like this. There will be no bending in the elbows. Our arms will be straight, and we will tilt the patient's head at any one direction, at either this direction or in this direction, so that when we are actually pressing to help the patient to breathe respiration, and also to push the water which is inside the patient's lungs, or in the abdominal cavity. So we are in the abdomen. So we are doing this to push out the water and to help the patient to breathe. So if you are pushing out the water will come out with the mouth or the nose, na? So that's why we are keeping the patient facing in any one direction. So what we will do? We will be bending forward, and we will apply pressure. We will be pushing abdominal viscera up to bring about respiration. Whenever we are pushing, na, because we are pushing the abdominal viscera, the diaphragm will rise upwards, so it will force the patient to have on expiration. And inspiration the patient will be doing by himself. We will not do anything for inspiration. We will be just pressing at the loin for around 12 to 14 per minute. Like whatever is the normal breath. What is the normal breathing rate for any patient? Yeah, 12 to 16 or 12 to 18. Some books it is 12 to 18. So in this case, around 12 to 14 times we will do this. We will put this pressure so that the patient is able to breathe in a normal respiratory rate. So we will be doing this for like the inspiration will last for 3 seconds. For doing this, how long we are doing, we have to keep a count. So for this, whenever we are here, we are doing like this, we will count like 1 to 3. Then we will press like for counting of 3 we will press, and 1, 2. Then we will count so the patient can inspire. The patient will inspire by himself or herself. So 1 to 3, then 1, 2. The patient will be inspiring again 1 to 3. So I have to measure in such a way that there are 12 to 14 breaths or 12 to 14 respirations in 1 minute. Everyone understood this or any confusion? You can see the picture. Picture there, na? The patient is lying down with his hands in front of his face, and the doctor is sitting near the patient in any side, in either the left side or the right side, wherever you are feeling comfortable, you can sit and you will press like this. You will count 1 to 3, and you will count then 1, 2, you will wait, then again 1 to 3. Now, what are the advantages and disadvantages? For every today I am going to tell you about some methods, but every method will have some advantage and some disadvantage. So, according to that advantages and disadvantages, whenever a patient of such condition of respiratory arrest is there, we will choose the methods accordingly. So, what are the advantages and disadvantages of Schafer's method? Advantages is it is done in prone position. So water from abdomen and lungs can be easily drained. So we are doing two things here. Whenever we are pushing, the patient is able to breathe out also, and the water which is collected in the abdomen and the lungs, they will be forced out. So two things are happening together. It is a very simple method, non-tiring. So you can do this. This is not that much tiring. You will do only 12 to 14 per minute. So it is you can do it for long time. So it can be continued for long time. If there are injuries to thorax or back, this method can be used. So if there is injury to the thorax or the upper back, so we are not using our force in the upper backs or the thorax. You are using it in the loin. So even if you are pressing also, there won't be any harm. Possibly there won't be any harm to the thorax or the loin. Any further harm is there if it is there. And one thing I forgot to mention, whenever we are doing this, it is preferable that if we put a pillow below the chest of the person. So it is not always possible that whenever you are present near a pond and someone is drowning, you will not go to your home and bring a pillow. Na? Obviously, if something is there, if some soft thing is there, we will put that below the patient's chest, and we will try as much as possible not to harm the patient, not to give any undue force. So what are the disadvantages? One is inspiration is passive, and expiration is active, which is unphysiological. So in this case, the expiration which you are doing, this is becoming an active process. So it is not actually against physiology. The inspiration he is taking by himself, we are allowing the inspiration to be taken by himself, or expiration we are doing by ourselves. So this is actually a reverse of what physiology teaches us. So another thing is, if there are injuries of abdomen, this method cannot be applied. So I've told you about the injuries of thorax and the upper back. But if there are injuries in the abdomen or like in the loin itself, then you cannot use this method. Obviously, if there is fracture of the vertebra in the lower portion, or if there is any abdominal injury, then you cannot do this method. If you are doing this method, then the abdominal injury will just increase. These things will be exaggerated. So these are the disadvantages of this method. So you have to use this method accordingly. Then there is Holger-Nielsen Method. This method is also done in prone position. These are the two methods which are done in prone position. There are other methods I will tell you that will be done in supine position. Prone position I have already told you. The patient will be facing the floor. The patient will be lying down and is on his stomach. Then that is called prone position. So here in the earlier method, the doctor used to lie down, kneel down near the patient's waist. But here the doctor is kneeling down above the patient's head. In front of the patient, the doctor will be kneeling. In the same position, arm position will be same, knee position will be same, like this, and we will be keeping our arms straight. And now we will be pulling the patient's arms and doing like this, so that it becomes more comfortable for us. And then there is one difference in this method. We will pull his arms up. Like in this method, we will take the arms of the patient and we will pull it up while inspiration. We will press while patient is expiring. We will press at the back below the scapula. We will do the similar way. The patient's arms will be like this. We will be pressing the back of the patient below the scapula. And then while inspiration, previous method, the inspiration was, we will not be assisting in the inspiration. But here we are assisting at the inspiration. We will be taking the patient's arms like this and we will pull like this. Once we will push, then again we will pull. When pulling, we are assisting the patient so that his lungs widen up and he can take inspiration by himself. We are assisting a little bit. So this is the difference in this method. Then doctor will leave his hands on side and put his palms on patient's scapula, and bending forward, he will apply deep pressure on his chest. This will cause expiration. So inspiration we are doing by pulling the patient's arms, then again we are keeping it here and we are pressing. This causes expiration. So again, like 1, 2, 3 and 1, 2. The same method we are doing for inspiration and expiration. You are able to see this picture. Here the doctor is sitting here, the patient is here. We are pulling the elbow like this, hands like this, and then again we are pressing at the back. The arms are here at the back. So what are the advantages and disadvantages of the Holger-Nielsen method? So main advantages of this method is adequate drainage of water from abdomen and thorax. So here we are pressing on the thorax and the abdomen itself. Now, in that case we are using the loin to press. So if you are pressing the loin, obviously this place will not be getting that much pressure. So if the water is mainly stored in this place, so obviously that water will not be excreted from the body in that way, in that manner. So we are doing this method, we are pressing in over the thorax. So in this case, the abdomen and thorax will be cleaned more. The water will be more drained at a more faster rate. So this is a good method in cases of drowning. So this method also can be used for drowning, and if there is no injury in the chest or abdomen as such, so this is the preferred method for drowning. And another advantage of this method is both inspiration and expiration are active. You remember in that previous method, the inspiration was not active, was being taken by the patient. And expiration also we assisted. Here we are doing both inspiration and expiration. We are assisting in both the conditions. So in this method, the ventilation is even more in comparison to that previous method. The disadvantage is this is a tiring method. So you are pulling the patient again. Again you are pulling once, you are pushing once. So you are doing two things together. So this is a tiring method. So it needs assistance. You might need someone else help so that you are getting tired. So someone else should be covering you, should be helping you. That okay, so for some time I am continuing this. Similarly, if there are injuries in the scapula, this method can be used. So this is common sense only, because if someone is having injuries in the scapula or in the thorax, then we cannot press it. For that we are using the previous method, as I already told you. So in those cases of injury in the scapula or in the thorax, we cannot use this method. Then there is another method called Sylvester's method. This one is done in supine position. So remember the previous two methods which we are doing, those two were in prone position. The patient was in prone position. Now there are two more methods which are being done when the patient is in supine position. Supine means the patient is facing towards you. So how we will do? It is in supine position. Pillow is given below shoulder and neck is fully extended. How do we extend the neck? Yeah. We will keep a pillow here and we will just lift the chin like this and we will extend the patient's neck as much as possible. We have to make sure that the tongue doesn't fall off in this case. So you might need some assistance. You can pull up the tongue so that it doesn't fall off and block the windpipe or block the respiration of the patient. So doctor will kneel near patient's head facing towards him. So like the previous method, doctor will kneel near the patient's head and will be facing towards the patient. He will catch patient's wrist and by bending forward, he'll pull patient's arm up. This will cause inspiration. So in that case, we are pulling the patient by his biceps or like near his elbows. In this case, we are touching this, pulling this part of the patient. Like this we are doing, and then we are pulling the patient's arm with the wrist or either with this front part of the hand. Then bending forward, he will put deep pressure on chest with patient's hands. This will cause expiration. Then bending forward, we will put the patient's arms like this over the chest of the patient, and we will press over the patient's arms. We will first do this. We will like keep the patient like this. We will press. Then the patient is expiring. Then we will extend the arms and then pull. We will pull like the earlier method, and then the patient will inspire. So that is for inspiration, and this is for expiration. So similar things, just we are keeping the patient in the supine position now. So inspiration usually lasts for 3 seconds and expiration for 2 seconds. So for your convenience, you can count 1, 2, 3 when you are pulling the patient's arms. Then again, we are pressing. You can count 1, 2, like 1, 2, 3, then 1, 2, like this. So that this count is maintained. The ratio is maintained. And we will do this similarly for all the methods. We will do for around 12 to 14 minutes, 12 to 14 per minute, 12 to 14 cycles per minute, so that the breathing rate is kept normal. This method also has some advantages and disadvantages. Advantages are both inspiration and expiration are active, so good ventilation. So like the previous method only also, the inspiration and expiration both are active, both we are doing by ourselves. So the patient's ventilation is maintained. The patient can take a good breath. And the disadvantage is, as patient is in supine position, there is no drainage of water from lungs. So this method should not be used in cases of drowning. So in drowning, we cannot use this method because we are keeping the patient in supine position. Na? So if you are pulling like this, then the water will further go inside. We are keeping the patient in supine position and we are pulling the patient, like pulling the patient's arms. The water may further go inside. The water will not be drained out. And water is not drained out in such cases, the patient's respiration may stop completely. So in that cases, we must hurry. As fast as we can give the artificial respiration to the patient. So again, this is a tiring method, so assistance might be needed. If there is rib fracture or thorax or like injury in the thorax, this method cannot be used. So if there is rib fracture, as I told you that we will be keeping our arms like this, the patient's arms like this, and we will be pressing for expiration. So if we are pressing, if already there is rib fracture, then that will cause even more fracture in the ribs, and the fractured ribs might damage the lungs. So in those cases, we cannot use. So like in cases of drowning and in cases of injuries like accidents where there is rib fracture, when there is trauma in the chest, preferably it is better not to use this method. Otherwise, we must risk to injure the lungs. And one is mouth-to-mouth respiration. This one is very common. I think most of you might have seen this in movies or somewhere, that mouth-to-mouth respiration breathing is given when someone is having difficulty in breathing. Someone has fallen down from somewhere, or electrocution is there, or due to any reason the patient is not breathing. In that case, we will give mouth-to-mouth breathing. So it is the best method of artificial respiration. So again, we are keeping the doctor or the person who is providing the respiration. He is kneeling near the patient's head. Again, we are kneeling down by our knees and our hands will be straight. And then first thing what we will do, we will just keep the neck extended. So we can put a pillow here or something whichever, a soft thing. Obviously, you cannot put a brick near below the patient's head. So something which is soft enough, we can put it there, and we can extend the patient's neck like this. Then we will grab the chin like this, and we will open the mouth of the patient, so that as long whatever range we can open, we will open the mouth as far as possible. And we will pinch the nose and then block the nose. So if you are because if you do not block the nose, and if you are giving respiration, the respiration will come out of the nose. So obviously you have to block all of the other areas in the face from where the breath will be coming. And before this artificial respiration, because many people might be infected by many diseases, so it is not actually that much preferred. And one thing more, that if there are any secretions or something else, in that cases, you have to clean that secretion first. Obviously, we don't want the secretion into your own face. Na? Obviously, you have to clean the nostrils and the mouth of the patient and the oral cavity. As far as possible, we will clean. Then we will start the respiration. Then how we will do? With left hand, patient's nostrils are closed. Tissue paper or handkerchief is put on patient's mouth. So in that case, if tissue paper is present, it is better so that you are not exposed to the patient's mouth and all. So doctor will blow expired air in patient's mouth. This will cause inspiration. So we will be blowing the expired air. Obviously, we are expiring that air. We are taking inspiration. We are expiring that air only. We are blowing. So we will be blowing that air into the patient's mouth. So in this case, when we are taking the mouth away, like we are giving force for inspiration, we are expiring. Patient is inspiring. So in that case, after we just pull our mouth back, so the patient is inspiring by himself. And one thing more I would like to add, this thing is beneficial because this sometimes helps the patient to regain that respiration because we are giving carbon dioxide. So that carbon dioxide may sometimes stimulate the respiratory centers. So we are giving this much of carbon dioxide in the patient's lungs, that will go into his brain. So that will stimulate the patient might start breathing again. So that will be helpful in that case. In this case also, the expiration will be passively. It will not be active. So what are the advantages and disadvantages of this method? Advantages of this method are giving expired air, which consists CO2, to stimulate the patient's respiratory center. So we are giving CO2, the patient's respiratory center is getting stimulated. The patient may start breathing by his own. So obviously we are successful, the patient is breathing by his own, then he can live a little bit longer till his help is there. Then good ventilation is obtained, obviously. We are giving air, so good ventilation is obtained. Inspiration is active, exhalation is passive, which is physiological. So in this case, we are not actually helping the patient to take expiration, but it is actually physiological. This should be normal. And it is the best method of artificial respiration in newborn babies. Like in newborn babies, they are this much small. We cannot give any other type of respiration. We cannot press in the thorax. So that will, all the bones will break. So we cannot also press in the loin. So in newborn babies or in small children, this is usually the preferred method. This thing can save those lives. And the disadvantage is, as this is in supine position, water from abdomen, if it is not drained by liquid, may regurgitate back into the lungs and then may lead to respiratory infection. So in this case, again in drowning patients, though it is used sometimes in drowning patients, but it is not actually preferable, because if we are pressing in the, keeping the patient, as we are keeping the patient in the supine position, water from the abdomen, even if it has not gone into the lungs, in those cases may go into the lungs and may obstruct the airway. So in that case, there might be even more damage than whatever help we are doing. So these are some of the mechanical methods. So after doing this, we will be doing this and we will call someone for help. So we will tell someone to call the ambulance or whatever, the police or whoever is coming there for help. So we will be waiting for the help and we will be keeping on doing the artificial methods of respiration. And these are the mechanical methods of respiration which will be done actually in hospitals. So we cannot, if you are in hospital only, then you can do these things. These things are not important for you at this level. So just know the names. The machine which work for mechanical methods of ventilation generally work on two principles. One is negative pressure breathing by alternatively compressing and relaxing the chest wall. The machines will compress and relax the chest wall. So that is one way. Example, drinker's method. And another is positive pressure breathing by introducing air or oxygen directly into the lungs, intermittently or continuously. Example, tank respirator. These are the earlier methods which are first used. So this is one is negative pressure method, which affects the lung walls or the thorax, the chest wall. Or another is positive pressure breathing, in which we are directly giving oxygen. Like in intubation or in ventilators, we do this normally. We are giving direct oxygen to the patient or direct air flow to the patient at a set volume, so the patient can keep on breathing. So these are the mechanical methods of ventilation. So suppose the patient, we cannot revive the patient. Suppose someone, the help is not coming, someone has gone to a beach or somewhere else, or gone to a river, which is like 10 to 15 kilometers away from any hospital. So we are giving him artificial respiration. In that case, suppose the patient has died. So the ambulance is not coming. The ambulance will take at least like half hour or 40 minutes. The ambulance is not coming. And you are alone with that patient. So will you keep on giving respiration for whatever time the ambulance will come? It's not that, no, we will not, it is not possible for us to keep on giving artificial breath for 1 hour, 40 minutes like that. So the patient might die in that case. So how can you know the patient has died? So that we will not give any more efforts to save the patient. There will be signs of death. Fixed dilated pupils which are not reacting to light. You can see the pupils are dilated. Obviously everyone nowadays uses a mobile or a torch. So you can use the mobile light to see if the pupils are fixed or dilated, or if they are reacting to or not. So if you see that the pupils are dilated, you can see that, you can see by experience that the pupils get dilated and they are not reacting or they are not stretching. And they are not reacting or constricting. So that is we can know that, okay, the patient has died. It is of no use if I give any more artificial respiration. Then no heart sounds heard. I already told you that we will be doing in patients in which pulse is present. We will be giving artificial respiration to patients only when there is presence of pulse and no respiration is there, but patient's heart is beating. But in this case, you will know that there is neither the patient's heart is not breathing, neither there is any pulse. We will check in the carotid artery. If there is no pulse, then okay, the patient has died. And there is no recordable BP. Obviously, it may not be possible always to record the BP, but this for your knowledge only, that there would be no recordable BP, no heart sounds, no pulse. Fixed dilated pupils will be there. So in that case, you will stop the respiration because it is of no use now. Patient has already died. So this is the brief of your artificial respiration.